Соединиться. Влево-вправо переключай слайдик.
А еще разок.
Стрелки влево-вправо слайдик переключай.
Сейчас.
Я нажимаю кнопку и вперед, да?
Today, anomalies of genito-urinary tract. Anomalies of genito-urinary tract are the most widespread since they are 40% of all congenital developmental anomalies of person and 30% of cases are combined with anomalies of genital and other organs. In accordance with the last data, we observe growth of such patients number that is explained by complicated development of genito-urinary system and impact of a good deal of unfavorable factors. Kidneys are formed of two primordiums, nephrogenic blastema and Wolffian duct. Nephrogenic blastema passed three stages of development: pronephros, initial kidney, final kidney, and gives rise to glomerulus and one of tubulus group. There are other group of tubulus, renal calyces, pelvis, ureter, bladder, urethral canal are formed from Wolffian duct. Kidneys formation occurs on 6-8 weeks of embryogenesis. That is why unfavorable factors impact, such as radiological and nuclear, chemical, medicinal, thermal, etc., in this period results in underdevelopment of these organs. It is worth mentioning that people with anomaly of genito-urinary organs may not even suspect that they have a developmental anomaly. Anatomic features of improperly generated organs, disorder of urine passage, frequent development of retention diseases. This is pyelonephritis. Pyelonephritis, this is inflammation of pyelocalyceal system. Hydronephrosis next. This is dilatation of pyelocalyceal system with bad drainage. And nephrolithiasis. Nephrolithiasis, this is formation of stones in pyelocalyceal system, bladder, and ureter. And next, renal insufficiency. Anomalies of kidneys. This is classification. Anomalies in number, anomalies in position, fused kidneys, anomalies in structure of kidney. Anomalies in number. This is aplasia or agenesia of kidney, duplicated kidney, and supernumerary kidney. First, aplasia of kidney. This is the result of halt of development of pronephros or initial kidney stage. The following methods of examination help to make a correct diagnosis of aplasia. No, first of all, this is ultrasound. First in investigation. During this investigation, we can see enlargement of single kidney and absence of contralateral kidney. Next investigation may be intravenous or excretory urography. This is functional method of investigation which show condition of kidney, function of kidney, and condition of pilocolithal system. On this picture you can see excretory urography. This is single kidney. You can see enlargement of pilocolithal system, big pilocolithal system. On contralateral side, you cannot see function of kidney. This kidney is absent. Next investigation. This is CT scan. No, this is also X-ray method of investigation, which show kidney, and sometimes if we use contrast, we can see function of kidney. On this picture, you can see that this kidney absent, on this side kidney absent, and you can see enlargement of single kidney and dilatation of pilocolithal system. Next method of investigation, this is cystoscopy. Cystoscopy, this is method of investigation of urinary bladder. During this investigation, we introduce special optical system in urinary bladder and introduce special liquid in urinary bladder, and we can see what condition of urinary bladder and one orifice, and on this side you cannot see orifice because this kidney is absent. "25 of observant of solitary kidney note malformation of genital system, such as duplication of uterus or vagina, which are formed also from Wolffian duct. Treatment of congenital solitary kidney usually requires this anomaly require no treatment, but it is necessary in cases of kidney affection by disease. No, if one kidney, only organ preserving operations are performed. This is pyelolithotomy, when we remove stone from pilocalithal system, or ureterolithotomy when we remove stone from ureter, nephrapexy. This is if patient with nephroptosis, and plastic surgery on urinary tract, such as plastic of surgery on pelvis or ureters. Next, this is supernumerary kidney. Supernumerary kidney is rather a rare anomaly. It is the third or even fourth separate additional kidney. Now, on this picture, you can see two normal kidney and additional kidney. Location of this kidney usually lower than usual. Each supernumerary kidney has its independent vascular pedicle and own ureter opening into urinary bladder, or a branch of main ureter of normal main kidney, general orifice. The diagnosis is made on the basis of excretory urography or retrograde pyelography when two pelvises are seen at a distance from one another and when there are two separate kidney images. Now we also use renal angiography, which help in complicated cases before surgical interference. This method of examination makes it possible to distinguish a supernumerary kidney from a duplicated kidney. Treatment arises only in diseases of the supernumerary kidney. Nephrectomy, this is surgical operation when we remove kidney. Nephrectomy is the operation of choice, since there is usually no need for open preserving operation. They are performed in cases of functional decrease of main RENs. Now, duplicated kidney. These kidneys can be defined due to extra urinary tract. Duplicated kidneys occur often enough in 10% of all urological patients. Pathological development goes by parallel formation of two ureter primordiums on Wolffian duct or splitting of one primordium into two branches. Shift of extra primordium to the site of urethra forming or to genital organs site result of ectopia. Now we distinguish complete duplication and incomplete duplication. But incomplete duplication, this is two pilocalithal system and one orifice in urinary bladder. This is one pilocalithal system, upper, and this is lower pilocalithal system. This is incomplete duplication, and if two orifices in urinary bladder, this is complete duplication. Well, this is one and another pilocolithal system. Duplicated kidneys are often accompanied with congenital ureteral defects, ectopia. Ectopia, this is not normal ending of ureter, not in urinary bladder, but maybe in vagina, in uterus, in prostate, ureterocele, blind ending of terminal or cranial ureteral segment, and stenosis of ureter or its valves. Angiography. Vascularization of duplicated kidney may be provided by one or more renal arteries, which separate it into branches and give separate terminal arteries to each of its parts. Now, on this picture, you can see normal kidney with normal kidney and normal vascularization of normal kidney, and this is duplicated kidney with artery to each part of duplicated kidney. One of methods, this is cystoscopy. I told you before that this is this method, this is visualization of urinary bladder. Now, on this picture, you can see two orifices in urinary bladder on left side. So, this kidney with complete duplication. Next method of investigation, this is excretory urography. When the kidneys is functioning well, both pelvis and ureters are clearly visualized, well as their morphological features and the functioning of each part. Note on this picture you can see normal kidney with normal pilocolithal system. This is pelvis, this is ureter, this is urinary bladder. On this side you can see duplicated kidney with two pilocolithal system. This is upper pilocolithal system, this is low pilocolithal system, and you can see two ureters. I think this is complete duplication. Treatment of duplicated kidney and their diseases. Now, first, this is conservative treatment. For this we use spasmolytics and catheterization of renal pelvis. Is aimed at improving urine flow from the upper urinary tract and relieving dyskinesia. No, such treatment we use if patient with severe pain, to decrease pain. One of problem of the duplicated kidney, this is intraureteral or so-called reflux, and dyskinesia of ureters. And also, if patient with complete duplications, we very often find vesico-ureteral reflux. On these pictures, you can see one of method of treatment. This is anastomosis between ureters. What in this case you can see stricture. This stricture was removed and pelvis connect with neighbor ureter. What you can see result of this operation. Next, this is intraureteral reflux with dilatation. Usually we can see dilatation of pilocalypsal system. And one of methods of treatment, this is high ureteropelvic anastomosis. What you can see that one ureter removed and end of this ureter connect with neighbor or low pilocalypsal system. No, I told you before that in mild or moderate grade of hydronephrosis, when the kidneys keep on functioning, plastic surgeries are performed. But значит, pylostomy, this is operation when we connect pelvis for good drainage. Next, pyloureterostomy, when we connect pelvis with ureter, neighbor ureter, and ureterostomy, when we connect ureter with ureters, one ureter and another. Next operation, this is heminephrectomy. This operation is recommended in cases of gross destruction of kidneys, reduced function of a kidney part, doubtful outcome of plastic operation. Now, on these pictures you can see this operation, heminephrectomy. No, if bad function of on left picture, I think bad function of upper part of duplicated kidney, and you can see resection of upper part of kidney with knife. And right picture show such operation, but we used special stapler UKL-60. Now on this picture you can see a result of heminephrectomy. Resection of during this operation was used resection of accessory ureter with ectopic orifice. This is excretory urography. You can see good function of the operated kidney. What? Low pilocalypsal system normal with good function, and chain of tantalum staples. This is also a result of УКЛ 60. Anomalies in position, kidney dystopia. This is next anomaly. Ectopia is the result of disorder of normal shift of ordinary bed in lumbar area. No turn around runs on occurs. Now, on this picture you can see classification of kidney dystopia. Well, this is thoracic location of kidney, lumbar, iliac location of kidney, and pelvic. And this is cross dystopia. Вот, as you can see on this picture, значит, вот, two kidneys on one side and orifice of one of kidneys on another side. Dystopic kidneys are predisposed to retention disease, hydronephrosis. Значит, this is dilatation of pilocolithal system, nephrolithiasis, formation of stones, and pyelonephritis. This is inflammation of pilocolithal system. No, if patient with kidney dystopia may be abdominal pain in indefinite location or pain in lower abdomen. In some cases, may be dysuric disorders, symptoms of disease of female genitals, gastrointestinal, nervous and cardiovascular system, and tumor palpated in abdomen. X-ray methods of examinations are leading technique in the diagnosis of dystopic kidney. This is excretory urography, which show what this is normal kidney, normal location of kidney, normal ureter, and this is dystopic kidney. You can see not normal location of kidney and short ureter. Short ureter, this is one of rentgenological X-ray symptoms of dystopic kidney. On next picture you can see also dystopic kidney. You can see not normal location of kidney and short ureter. This is kidney scintigraphy. No, this is one of functional methods of investigation, which show first of all function of kidney and location of kidney. On this picture, you can see that normal kidney with normal location, with good function, and this kidney, location of this kidney lower than usual and not normal function. The function of this kidney decrease. Now about treatment of dystopic kidney. People with dystopic kidneys that have no clinical manifestation of disease require no treatment. Surgery should be performed in all cases of hydronephrosis, concomitant infection, disorders of renal function, and nephrolithiasis, frequent renal colic. No, and usually we use operations which we use if normal with normal kidney. Next, this is fused kidneys. Next anomaly. Anomalies of interrelation. These anomalies are characterized by fusion of two renal primordials during 8 weeks of embryogenesis into one organ. Its ureters ending in ordinary place. There are many variants of fusion according to form and relation to vertebra. Now what on this picture you can see horseshoe kidney which fused in low pole, and you can see bilateral duplication of kidney, one pilocalycal system and another. This is next horseshoe kidney which fused in upper pole. This is next. This is cake kidney. You understand, cake kidney as cake. Fusion occurs in low pole in 90%. Isthmus can be parenchymatose or fibrose. Pelvis located on anterior surface. The fused ring can be 1 or 10 arteries enveloping and fixing organ. What on this picture you can see vascularization of horseshoe kidney. What many arteries to this kidney with blood supply of isthmus. Now about examination. No, we can use excretory urography. One of very important rentgenological symptom of horseshoe kidney, look here. Localities look to isthmus. One X-ray, next X-ray also. Localities look to isthmus. Next examination. This is scintigraphy of kidneys. No, scintigraphy, this is, I told you before, this is functional method of investigation. And you can see what function of horseshoe kidney and what this is isthmus. Function in isthmus. Next, this is vascularization of horseshoe kidney. This is angiography, and this is parenchymatose phase of angiography of kidneys. What you can see horseshoe kidney, and this is isthmus. Extraordinary anatomy favors urostasis in prepelvic part of ureters and development of pyelonephritis, hydronephrosis, and nephrolithiasis. No, usually it can be compression of ureters by isthmus or by accessory vessels in halus of pyelocalycal system, and maybe compression of ureters and pelvis, and we very often can see stones in pyelocalycal system, hydronephrosis, and recurrent pyelonephritis. So now surgical treatment. Two groups can be distinguished: operation without transection of renal isthmus and operation with transection or resection of isthmus of anomalies organ. No, we can remove only, for example, stone from pyelocalycal system. Sometimes we can do a plastic operation on pyelocalycal system, but sometimes, what as you can see on this picture, we can do such operation with resection of isthmus. What you can see, resection. And at the end of this operation, you can see two normal kidney. Now, anomalies in structure of kidney, cystic disease of the kidneys. Simple cysts are divided into congenital, primary, and aqueous secondary cyst. No, congenital is formed as a result of single legs of sequence of convoluted and straight renal tubules, and acquired is formed after infarct of REN, pyelonephritis, nephrolithiasis, is a result of ischemia and inflammation and urostasis. What solitary cyst, either round or oval in shape. The contents of the cyst, usually serous, rare, hemorrhagic, may be localized in various parts of organ. Subcapsule, interparenchymatous, cortical, peripelvic, what is there, and multilocular, and may be different and can be cyst different size, as from 1, maybe 2 and to 10 and more centimeters. No, solitary cyst usually has no specific symptoms. Is found occasionally on urological examination. No, usually may be pain in lumbar area, palpated tumor, total hematuria, and arterial hypertension. No, more often we can find pain in lumbar area, dull pain in lumbar area, and hypertension. This is main symptoms of solitary cyst. Complications of solitary cyst: hemorrhage, disruption of cyst, suppuration, formation of concrements in pelvic calicovascular system. Treatment of solitary cysts. Small cysts, 1 or 2 centimeters until 4 centimeters. Need to no treatment. Large solitary cysts in a renal pole allowed to puncture under ultrasonic control, aspiration, and injection of sclerosing solutions in the cavity. No, usually we introduce 96 ethylic spirit. Puncture is carried out under local anesthesia. Percutaneous puncture of cysts of kidney is a traumatic method and often allowed to refuse surgical intervention. No, this is one method of treatment, puncture. And sometimes if big cyst, we use resection of cyst and with during open surgery and laparoscopic surgery. Acquired secondary cyst. Acquire in case of maybe if patient with pyelonephritis, nephrosclerosis, tumors, tuberculosis, hydrochalicosis. What you can see different acquired cyst. Treatment such as if patient with usual solitary cyst. Now, polycystic kidney disease is frequent, inherited by autosomal dominant anomaly. Is always bilateral process. It may appear in children, but is usually diagnosed in adult life. Defect occurs due to ill-time conjugation straight and convolute tubulus formed from various primordiums in embryogenesis of secretory and excretory nephrons segments. What you can see on this picture, polycystic disease, multiple cysts in kidney. These cysts compress parenchyma of kidneys, and this affection of parenchyma not good for patient. End of this disease, this is renal insufficiency. Polycystic kidneys are often combined with polycystic liver, pancreas, spleen, lungs, ovaries, and also with aneurysm of cerebral arteries, etc. Polycystic kidney disease has various manifestations. Dull pain in lumbar is the most common symptom due to disturbed flow of urine. Circulatory disorder of kidney, inflammatory process in kidney. Pain in epigastrium may be caused by displacement of abdominal organs, by large cystic kidneys, and by considerably increased of intra-abdominal pressure. Arterial pressure in many cases very high. In 20% of cases, cardiovascular disorders may be the only manifestation of polycystic disease. Cardiovascular disorders are manifested by pain in the heart area, retrosternal pain, headache, and disease. 3 stages of clinical course of polycystic disease. This is first stage, this is compensation, second subcompensation, and third decompensation. From methods of investigation, very important, this is ultrasound examination, which show multiple cysts, first of all, enlargement of both cysts, and multiple cysts in both kidneys. Next examination, very important for us, this is CT scan. Well, this is CT scan. What you can see, enlargement of both kidneys. What, and multiple cysts. Such kidneys, during operation, looks like grapes. Since treatment very difficult. Since polycystic disease is a bilateral process which tends to progress, and end of this disease, this is renal insufficiency. No, if first stage of this disease, we use conservative treatment. We give diet and physiotherapy and drugs which decrease arterial pressure. No, this aim of this treatment, this is elimination of infectious process in urinary tract and control of renal insufficiency, anemia, and hypertension. If patient with second stage, with not with high arterial pressure and with high level of urea and creatinine of blood, we use surgery, because conservative treatment sometimes not effective. No indication for surgery. This is persistent pain in renal area, large cyst, particularly in region of renal hilus, recurrent total hematuria, suppuration of cysts, hypertension resistant to the hypertensive therapy, tumor or tuberculosis in polycystic kidney, concrement in kidney and ureter. All this this is indication for surgery. No, what surgery we use? This is decompression of polycystic kidney with by multiple punches and emptying of cyst with ignipunctura. No, we crush big cyst with scalpel. No, small cyst we cannot crush. So after 3 or 5 years after surgery, we can see the same picture as before surgery. This is high arterial pressure and signs of renal insufficiency. No, sometimes we use percutaneous puncture of cyst under ultrasonic control, operation of De la Pena. No, without incision in lumbar area. Oh, stop. No, and the best way for these patients, this is transplantation, hemodialysis, and transplantation of kidneys. Thank you for attention and anomalies. No,